Good afternoon, everyone. We will kind of jump into the materials that you'll be seeing today, and just thought we would start out with some introductions of those of us from HCA and HBE in the room. This is Christine Joubert. I'm Associate Policy Director at the Exchange.
Molly Voris, Chief Policy Officer at the Exchange.
Penny Adler, HCA Project Manager.
Rachel Quinn, HCA Special Assistant for Health Policy and Programs.
I will just note, we also have Ben Diedrich and Cheryl Wong from Milliman with us on the line, and you'll be hearing from them later in the presentation. Just starting off with the agenda, I'll be kind of just looking at a glance at the overall work plan for Cascade Care that we've been engaging in with our partner agencies thus far for the past several months, and then giving you an update of where we've come with the standard plan development. And then HCA will be really getting into the discussion with you all about the kind of their contracting and procurement role in Cascade Care, the purchasing and procurement standards and their approach to those standards that they've kind of been working to develop and are reaching out now to you all to get feedback on, and their timeline and next steps for those activities. And then we will be hearing from Milliman to talk a little bit more in detail about the affordability requirements that are in development. And as Pam mentioned, we really want to make sure we reserve time for a Q&A for you all to then ask your questions to the group. So moving forward, just kind of an outline of the Cascade Care bill itself. The bill is organized into three parts. And just a highlight of those three parts, the first are the standard plans. And really the standard plan portion of Cascade Care has the goal of making the plans themselves more accessible to consumers by looking at lowering deductibles, making cost sharing more transparent, and providing services before the deductible. Then there is the public options section of the Cascade Care bill. Here, the goal really is driving toward more affordable plans that would be available across the state, and that's really looking to lower the premiums, and also to include some additional quality and value requirements in the public option plans. And then third is a subsidy study. So this is an effort that will be led by the Exchange to work on working on a plan to think about how subsidies could be available to individuals up to 500% of FPL. And what's going to happen over 2020 is we'll be working on a report and presenting to the legislature in November 2020 on that study. So we just want to acknowledge that this really has been a multi-agency effort so far and will continue to be so. The Healthcare Authority, Health Benefit Exchange, and OIC are working closely together on all parts of this development of Cascade Care for 2021. And we want to share with you kind of a little bit of the detail about the timeline that we all three agencies have been working on over the last several months, and then we'll be working on through 2020 to ensure Cascade Care is ready to go for 2021. So you'll see a timeline here, just kind of noting we've divided the work streams into HBE, HCA, and OIC. Just noting HBA has done a lot of work with the other agencies and with numerous stakeholders so far in this year to develop the standard plan designs, which will be and kind of are in the process of being handed over to HCA now to be included in the procurement for public option plans. HCA has been working with us on the standard plans as well as developing the RFP criteria for the procurement, and then we'll really launch into that procurement at the beginning of 2020, leading up to public option plans being determined and contracts being signed in September 2020. That work really aligns well with OIC's role, which is to be the regulator of the plans in the individual market. All of the public option standard plans are still participating in the individual market and will meet OIC's regulatory requirements throughout the spring and summer as they lead up to review and approval of plans for 2021, around that same September timeframe that we're expecting all those plans to be approved. So moving forward into the standard plan discussion. just wanted to give you kind of a quick recap of where we have kind of come in developing the standard plans and where we are now. So just kind of the lay of the land of standard plans. Beginning in 2021, all exchange carriers will be offering at least one gold and one silver standard plan. And then if the carrier chooses to offer a bronze, we'll also offer a bronze standard plan. Non-standard plans will continue to be offered alongside the standard plans. And the standard plan designs will be the basis for the public option plan. So any public option plan will have that same standard plan design. We will be annually looking to update the standard plan designs, so they will be adjusted annually for some changing federal requirements. The next slide tries to lay out for you the different types of plans that will be available through the exchange starting in 2021, just because it can get a little bit confusing with these changing requirements. We're just kind of showing the requirements for all plans in the exchange. So non-standard plans, standard plans, and public option have a core set of kind of exchange requirements that will continue to be the case for all plans. And then just kind of showing the difference of the standard plans. So you can see kind of in the middle of these rows, the unique plan design with the set copays, deductibles, and coinsurance amounts, services guaranteed before the deductible, and allowing consumers to easily compare one plan to another that have the same cost sharing. Those are the features of standard plans. And then there are some additional requirements on top of the standard plan requirements that will be included in the public option procurement. So moving forward, we just wanted to give you kind of a recap of the development process for standard plans that we've been engaging in over the last several months. As I mentioned, the exchange has been working really closely with HCA and OIC throughout this process in the development of the standard plans. We have also convened a few work groups. So we've been working closely with carriers, as well as consumer advocates, providers, and business and labor representatives to make sure we have really that full spectrum of feedback as we've developed the plans, as we've gone through kind of a number of iterations of the plan designs. The exchange contracted with Wakely Consulting, who helped us in designing the plans and really kind of meeting all those actuarial value requirements of the plans. And we also went through a public comment period that ended somewhat recently. So it was a month long, October 18th through November 18th. We received public comment on the plans. A couple of weeks ago, the exchange board met to approve the plans and did approve the plan designs on December 5th. And we just wanted to make sure you had this link here for any other information and materials about the plan designs. You can visit this link. So in thinking about the outcomes that we were seeking from the plan designs throughout the development process, we were really looking to see if we could lower deductibles for consumers, make sure that consumers were able to access kind of the most cost-effective and most essential services before the deductible. And this includes in all the standard plans, preventive care, primary care, urgent care, mental behavioral health care, and generic drugs. And then also looking to really include copays where possible. We understand that for consumers, copays make plans much more transparent and help them to understand what their cost will be when they go and seek services from a doctor, and allows them kind of transparency into what their expectation can be as they're planning for their year and as they're needing to seek medical care. We also really kind of were striving, especially with the bronze plan, to make sure we could include some high value services before the deductible, but potentially also aim for a lower price point through the public option. So that was some balancing that took place for that bronze plan. And then we really just wanted to make sure that through this process, we're able to offer high value plans for every consumer in every county in Washington. Also keeping in mind throughout this process that the standard plans would be the basis for the public option, and we really want them to be a good, solid foundation for the public option plans. So now we're just showing you actually what the standard plans look like. So this graphic is showing you a standard gold plan next to the silver, next to the bronze. You'll see at the top, there's a line for deductible. So this is the consumer's deductible they will see in each of the standard plans. And then down the chart, you will see the consumer's portion of cost sharing they will face when they seek each of these categories of services. You can also see the light blue shaded boxes. These are services that are available before the deductible. So you can really see, especially with that gold plan where we have really provided for transparency for the consumers through the all copay structure, as well as providing a number of services before the deductible, also in the silver plan, having those same aims to really make the plans useful for consumers who need to seek care. So just wrapping up the standard plan discussion for next steps around standard plans. As I mentioned, the plan designs have been approved by the Exchange Board and have now been handed over to HCA to include in their procurement for the public option. And the Exchange will be really delving into developing marketing and research materials for the Cascade Care plans. We're planning on holding some focus groups and doing a lot of consumer research and testing to help us to be able to present these plans in a way that really helps consumers get to the plan that's best for them. So at this point, I'll be handing it over to Rachel Quinn, who's going to begin to discuss with you HCA's role in procurement for Cascade Care.
And welcome. Good afternoon. As Christine mentioned, the Cascade Care legislation directs HCA in consultation with the Health Exchange to contract with health carriers to offer state procured standard quality public option plans for 2021 plan year. Again, these plans will be available through the Health Benefit Exchange and will maintain all federal and state requirements for QHPs. Carriers that choose to participate must offer gold, silver, and bronze standard benefit designs, as Christine just discussed and outlined, that have already been approved by the HPE board. And then the legislation also directed provider reimbursement rate methodology and caps, as well as certain quality and value requirements, which the next series of slides I will present, and then Milliman, our actuary, will, after I finish, will present the provider reimbursement methodology approach that we are considering at this point. So the legislation in terms of the Cascade purchasing standards, the legislation outlines, affords an affordability opportunity for Cascade Care, which directs that the Cascade plans will have reimbursement caps and floors for health carriers, payment to providers. The cap is set at an aggregate of 160 of Medicare. The floor is set such that primary care physicians may not be paid less than 135% of Medicare, and that rural critical access hospitals and sole community hospitals are not less than 101% of Medicare allowable costs. It also directs some quality and value participation requirements be part of the Cascade plans. It directs that these public option plans must incorporate recommendations of the Robert B. Collaborative and Health Technology Assessment Program, as well as additional requirements that align to state agency value-based payment purchasing that focus standards and requirements that focus on maintaining and improving health. So I'm going to talk a little bit about our proposed approach for the BRE recommendation as well as HTA. But before I do, I want to take a step back and talk about how we developed our approach on developing these purchasing standards for Cascade Care in 2021. HPE staff, as well as the Healthcare Authority, created guiding principles for program development. And this slide outlines the three guiding principles. One is we strive to increase affordability and value while aligning with state purchasing standards. As most people know, the Healthcare Authority, as the largest purchaser in the state, has incorporated a lot of value-based payment and purchasing requirements in its contracts over the last couple of years, and we've taken a hard look at what has been done there and what would be applicable to incorporate into the public option plans. Second, and very important, Success is dependent on carrier and provider participation. Therefore, administrative barriers to participation should be minimized. And then last, program development and refinement will be a continual process. This is a marathon, it's not a sprint. This is our first year, and so we're looking for initial development that will lay the groundwork for phasing in additional requirements and standards over time. To start off, for the BRIE collaborative standard approach, as I mentioned, the legislative requirement is the public option plans must incorporate recommendations of the Robert BRIE Collaborative. For those who may not be familiar with the BRIE Collaborative, the BRIE Collaborative is a multi-stakeholder collaborative that was created by legislation in 2011 to help identify and propose recommendations for health topics that have high variation in cost and quality. And the BRIE Collaborative is run out of the Foundation for Healthcare Quality and has generated multiple reports over the last 8 to 9 years, and it has a robust website where all the recommendations are posted and more information on the BRIE Collaborative can be found. Our proposed approach at this point is participating Cascade Care carriers will be required to implement a subset of BRIE collaborative recommendations and report on progress during the year. I will note that the BRIE recommendations are broken out by stakeholder, and so the carriers would implement health plan recommendations, which is in the implementation section of the BRIE collaborative website. The proposed approach would be that the healthcare authority will select a subset of topics for all carriers to implement, as well as ask each carrier to select a couple other recommendation topics for them to implement and report progress on the first year. These are the 5 recommendations that the 5 topics, BRIE recommendation topics that we are proposing for all public option carriers to implement the first year. And they are elective total knee and total hip replacement bundle, hospital readmissions, behavioral health integration, opioid use disorder treatment, and low back pain. And then the next slide are the additional BRIE collaborative topic areas. Again, as I mentioned, and all these recommendations can be found, recommendation reports can be found on the BRIE collaborative website. And then next slide, there's a couple other areas in development for 2019 that are just finishing up or are in final stages of finishing up. And the BRIE has also selected some topics for 2020, but those will not be considered for Cascade plans over 2021. So the next standard approach is the proposed health technology assessment standard approach. For those who aren't familiar, the health technology program uses scientific evidence to determine if health services are safe and effective. The Healthcare Authority runs and oversees the HTA program. We staff a health technology clinical committee, which is made up of providers, and they review evidence-based reports on selected medical devices, procedures, and tests, and then they make coverage decisions that apply to state purchase programs. As I mentioned, Cascade public option plans must incorporate recommendations of the Health Technology Assessment Program. Our proposed approach is for Cascade carriers, require them to provide a baseline report on alignment of their coverage criteria to HTCC decisions and report progress made during the year. Oh, the next couple of slides show there's many coverage decisions or review areas that the HTA has reviewed. This is all on the Healthcare Authority's website, as well as links to these reports. Next slide. As you can see, there's a wide variety of coverage topics and decisions. Next, the legislation, as mentioned, it directs a reimbursement for primary care services, has a floor of that primary care will be paid no less than 135% of Medicare. The legislation defines what the provider will be in terms of what a primary care provider is. And the legislation defines primary care, specialty designation of family medicine, general internal medicine, and pediatric medicine. But the legislation directs that the reimbursement for the services, primary care services, will be defined by the healthcare authority. The healthcare authority has been doing a lot of work around primary care over the last year or so, including developing a primary care definition to be used to measure primary care spend as a contract requirement of Medicaid, public employee, and school employee contracts starting in 2020. The State Office of Financial Management has also been working on a definition of primary care. And so what we plan to do is leverage those definitions that have been vetted by providers, the primary care services definitions that have already been vetted by a small group at OFM, as well as clinical leadership at the healthcare authority for the primary care reimbursement definition. And then the healthcare authority will be providing those codes and definitions in procurement. Cascade legislation also includes a mandated exemption. Providers participating in all QHPs, including the Cascade plans, are eligible to receive a B&O tax credit. The B&O tax credit applies to amounts received by a healthcare provider for services performed on patients covered by state-procured standard QHPs, which are the public option plans, including reimbursement from the qualified health plan and any amounts collected from the patient as part of his or her cost-sharing obligation. Our proposed approach is to require a use of a plan identifier to uniquely identify public option plans and or identify public option plan enrollees through the creation of an enrollee ID, so those providers can get credit. In terms of next steps, there's been a lot of work to date, mostly on as Christine, you can see from Christine, they have done a lot of work on the standard plan design and have been working on that for the last more than a couple months. And there's different work groups that had been created. The exchange has leveraged existing work groups, and that's happened since October to December. The healthcare authority hired Milliman to help start working on the methodology for the rate reimbursement over the last month or so. The healthcare authority plans on releasing some of the proposed requirements that I discussed today, as well as others, in a public comment period starting very shortly into January. So please, we encourage any and all providers to respond to that, as well as the general public. And we will be sending out more information on that shortly. We plan on releasing the Cascade Care procurement and solicitation in approximately around February 2020, and finish our review of the procurement in spring 2020. As folks might be familiar, the OIC will need to conduct their review and approval of plans with a rate filing in May 2020 with approval in September, as well as the Health Benefit Exchange Board will be planning on certifying plans in September 2020. Here are some websites of what I cited today for additional information on the BRE health technology assessment reviews, as well as the HCA Cascade website. And then the Exchange also has a very similar Cascade website. And the next slide is the general question email, Cascade email box. If you have any questions, please email us at that email address, as well as Michelle Needham, who's the Chief Policy Officer at the Healthcare Authority, who wasn't able to be here today. Feel free to email her or anyone who is also on this webinar today. But this concludes HBE and HCA's part of the presentation. I'd like to turn it over to Ben Deirdrick and Cheryl Wong at Milliman to discuss the affordability standards.
Okay, Ben's on.
Can everyone hear me?
Yep. We can hear you, Ben.
Great. Thanks, Rachel, for the introduction. My name is Ben Deirdrick. I'll be talking today about our preliminary initial draft. And I say those two words with emphasis to make sure that everyone understands we are still developing this methodology, and the methodology under development will be used to assign Medicare prices to all of the claims for the carriers that will ultimately be participating within Cascade Care. Like Rachel said, there's a few cost components to the evaluation of affordability, and this methodology addresses those main cost components. So if we could go to the next slide. The next one's the data reliance and limitations. We will be presenting some results at the end of this presentation related to the public employee benefit plan experience. So that information was relied upon without audit from the vendors that service that plan. Next slide, please. Give you a bit of background on the enabling legislation to sort of double up. This presentation was presented to the carriers last week, and so we didn't have the benefit of all the great background material that was just presented. But if we go through, we can see that the cost criteria has a ceiling on provider reimbursement that's at the average statewide level of reimbursement, and it excludes pharmacy costs, and that may not exceed 160% of the amount that Medicare would have paid reimbursed providers, I should say, and facilities for the same or similar services. There's also, in addition to the ceiling, a floor on rural hospitals, where the legislation has defined rural hospitals as either sole community hospitals or critical access hospitals as certified by CMS. And these two facilities must be paid at least 101% of their allowable cost. As you'll see later, we're still working out some of the details specific to the sole community hospitals, so that's probably an area that may change in the future. The second floor is for primary care services. Like Rachel mentioned, the reimbursement for those services that HCA is going to find will be at least 135% of the amount of Medicare would reimburse. Our presentation also includes a link to the bill, and the common thread through each of these cost criteria for the Cascade Care network is that the measurement is of actual reimbursement by the carriers that are selected as Cascade Care plans relative to Medicare. So this methodology is not able to evaluate future historical performance or future performance. It's only established to analyze historical actual results. And we'll get a little bit more into that detail, but this process will be the same process that is ultimately used to validate and verify what the networks actually produced for discount arrangements once they're selected as the Cascade Care plan. So the general idea is that we're releasing this methodology now so that the carriers can contract with providers in a manner that will hopefully result in the expectation of 160% of Medicare reimbursement being achieved in the future. Next slide. So just to give you a quick overview of the Medicare pricing methodology, we will be starting with all the data fields that are available within the processed claims file for each carriers. And we will assign every medical claim line a Medicare amount that's associated with that claim. So if there's instances where a claim line is bundled and presented as a case rate in the instance of inpatient, all of those claim lines will be associated together. If there's an outpatient claim or a professional claim where the individual claim line is reimbursed separately by Medicare, we will also recognize those values as well. And what we're doing is when we're assigning a Medicare allowed amount to every individual claim, then we're able to take the sum total of all the actual allowed claims that the carrier has provided for coverage divided by the Medicare allowed amounts associated with each of those claims, and that gives us the percent of Medicare performance that the provider contracts have yielded. I should say that when we're assigning Medicare to every claim line, there's several considerations / issues that need to be considered. And those are where if you have identification of a National Provider Identification or NPI code or a Medicare certification number associated with the provider, if those are unrecognizable within the processed claim data, then the Medicare fee schedule is impossible to identify. So we've included within the methodology some default assumptions that we'll be making in those instances. The other piece of background is that you need to make a determination of the applicable fee schedule year. So Medicare varies their reimbursement for inpatient services on a federal fiscal year basis and for outpatient and professional services on a calendar year basis. So for the inpatient side, we had to make a determination of which federal fiscal year we were going to use, and so we elected the federal fiscal year ending within the contract year of analysis, and so that will be explained in further detail in the next slide. So the fee schedule year is beginning on October 1st of each year for inpatient. That will be the fee schedule that we'll use to evaluate the following calendar year. So there will be 9 months of overlap and then 3 months of cost that will be incurred and evaluated against the prior year's federal fiscal year level. So for example, the CMS schedule as of October 1st, 2020, that will be the federal fiscal year 21 fee schedule that will be used to evaluate any calendar year 2021 claims data. The CMS outpatient hospital, as I said earlier, and professional fee schedules go into effect on January 1st each year. And the Cascade Care networks will be effective on January 1st, 2021. Next slide. So the main methodologies that Medicare reimburses providers today are prospective payment-based. So we have the inpatient prospective payment system, or IPPS, and that will be used for any claims where a room and board revenue code are identified. We internally will be using the Milliman Health Cost Guidelines grouper logic to identify these inpatient claims, but the carriers, when they're able to contract with providers, should be able to identify the same room and board revenue codes for evaluation of what will be determined on IPPS. The other piece that is required is the ICD diagnosis and procedure codes. Those will be used to assign the Medicare Severity Diagnosis Related Group, or MSDRG. The MSDRG for an IPPS reimbursement under Medicare determines the amount of the case rate that's applied. And we will also be making an outlier payment adjustment based on the provider-specific cost-to-charge ratio. So as I said earlier, every claim that a carrier has incurred under Cascade Care, we will work to identify the MSDRG associated with that claim, as well as any outlier adjustments that may need to be made for that claim. as well as any specific area adjustments that could apply to that specific provider. If in the case where we don't have a valid NPI code, we will assign the default Medicare reimbursement amount based upon the Seattle average outlier adjusted for the MSDRG. And this, I will remind everyone, is our initial preliminary draft. And so this is also going to be subject to change as we go through public comment. The next slide is the Outpatient Facility Prospective Payment Methodology, or OPPS. This applies to all facility claims where the revenue and facility type are identified not to be an inpatient prospective payment nor a professional fee schedule reimbursement. So this is sort of the default outpatient methodology. For this, we only need procedure code. We don't need diagnosis code, and it will be used to identify which fee schedule is applicable, if that's the ambulatory payment classification amount for under OPPS for facility-based reimbursement hospitals, or if it's the ambulatory surgical center or ASC payment amount for those ASCs within having these claims. We again use the NPI code to determine the area adjustment factor for the OPPS fee schedule. And for providers without a valid NPI, we will assume that the provider is located in Seattle. And then the ancillary fee schedules are also incorporated into the OPPS analysis. So we have clinical laboratory services that will be evaluated as the professional fee schedule indicates. And then we have the RBRVS for physical therapy that may occur within the outpatient facility setting that we'll also be discussing on the next slide. And for outpatient procedure codes that are not on the Medicare fee schedule, we will be having to create the similar services mapping. So those services are what don't fall under the HCPCS or Healthcare Common Procedure Coding System. And so for those, we will have to work to identify what the similar service substitution is going to be. And we plan to publish as part of the methodology report an appendix that identifies code by code what the corresponding substitution is on a HCPCS level basis. So the last main reimbursement on a prospective payment basis is the professional fee schedule assignment. And professional claims are identified either as not having a revenue code or one of the following revenue codes that are listed. So this will be how we go through and identify all the professional fee schedule eligible claims. Medicare amounts will again be assigned based upon the HCPCS code and the fee schedule year of the calendar year that we're evaluating. The main fee schedule is the resource-based relative value system, or RBRVS for professional reimbursement, but there's also fee schedules for various service types of ambulance, anesthesia, Part B drugs under the ASP fee schedules, durable medical equipment, clinical laboratory, and perinatal and enteral nutrition items and services, or PEN. So all of these fee schedules have an eligible Medicare reimbursement that will be assigned to all those claims that are covered by Medicare. And if we don't have an NPI code to determine the geographic area adjustment factor, then the methodology for evaluating Cascade Care Medicare prices will again default to the provider is located within Seattle. And for the same situation as we had on outpatient prospective payments, for professional procedure codes that are not covered under one of the Medicare fee schedules identified previously, we will use some substitution of a covered HCPCS and assign the fee schedule as we would have done for that similar service under the Medicare fee schedule that's appropriate. Next slide. In addition to the prospective payment methodologies that Medicare has, they also have some facilities that are reimbursed at cost. And those facilities include cancer and children's hospitals, where Medicare reimburses them at 100% of reported cost. Then we have the critical access hospitals that Medicare reimburses at 101% of reported cost. Here is where we talk further detail about the sole community hospitals, where the legislation mandates that they be paid at 101% of reported costs, which is different from how Medicare reimbursement would be assigned for these hospitals. But Medicare reimbursement would be under a prospective payment system approach, and it would just include a sole community hospital adjustment factor. So we're still evaluating exactly how we'll be measuring the Medicare reimbursement for the sole community hospitals, but we will be consistent under this presentation and this draft with evaluating them on a cost basis. When we're evaluating cost basis, the cost reimbursed facilities will have evaluation under a published cost to charge ratio. The cost to charge ratio is analysis that's performed by Medicare and published through their cost reports. And so there's quite a bit of time delay of when the cost report information is available and to when the network is going to be evaluated. So what we plan to do is publish the 2018 cost to charge ratio, and if available, we will publish the 2019, or when available, we will publish the 2019 cost to charge ratio. And between these two values, we will determine what the 2021 cost to charge ratio in advance will be for the evaluation of Medicare reimbursement to these hospitals. And similar to the HCPCS substitution services, we will have what the published cost to charge ratio is for these hospitals that are evaluated under cost reimbursement. And then we will make the assumption that the charge trend is consistent with the cost trend for evaluating future years. Next slide. Because this is just a preliminary draft, we have most of the methodology defined, but there are still some components that we still have in progress. Those are listed on this slide. Specifically, we have some psychiatric hospitals, we have rehabilitation centers, long-term care facilities, hospital facilities, skilled nursing facilities. All of these are reimbursed by Medicare through methodologies that we at least have not within Milliman developed readily available repricing methods. So we will be most likely looking to include these under the cost to charge ratio. We don't anticipate this to be a material amount of utilization for the evaluation of Cascade Care. That is, however, based upon our public employee benefit program experience. So we could find as we go through the course of the next 12 months that there is a significant utilization issue that we need to figure out how we're going to evaluate. But for now, we are anticipating using just the same cost to charge ratio methodology that we would be using for critical access hospitals. Next page. Then when you're always going through and trying to assign all the claims individual Medicare amounts, there's some exclusions that have to take place. So these are payments beyond the direct fee schedule that we've been able to identify that we could consider in pricing methodology or could not consider in our pricing methodology. Mainly because of time. Some of these are lump sum amounts that are not available on a timely basis. Other amounts are able to be recognized as a percentage increase or decrease to the base reimbursement rate of a prospective payment system, for example. So these adjustments to reimbursement are currently excluded in the methodology, and they include the indirect medical education payments, the disproportionate share hospital payments, and the associated uncompensated care payments, any provider settlements that may occur with Medicare, any sequestration adjustments that Medicare may apply to the fee schedule, any Medicare claim edits. So Medicare sometimes will go through and make claim edits to what the covered services are. We are not able to apply that claim by claim logic in our repricing approach. We also have bundled payments and risk sharing that CMS programs may impact reimbursement on. Those are not reflected within our repricing approach. Lastly, we have the inpatient new technology payments, capital payments for new hospitals, physician area professional shortage areas, and physician incentive payment adjustments, i.e. MIPS. Next slide. In addition to the exclusions that could affect reimbursement, we also have some general data quality exclusions. So we will be working with each of the carriers under Cascade Care to try and minimize the impact of data quality and try and ensure that we have a high representative sample of what claims are being reimbursed under these plans. But we will make some following data reviews just for reasonableness sake, and that's that we will look at member-based ages over age 65 in case there's some Medicare eligible or potentially Medicare eligible participants enrolled within the individual market plans. We also be looking at any claims that have a coordination of benefits adjustment. The reason we adjust for coordination of benefit claims is because in those instances, the carrier may be reporting an allowed amount that is secondary or an allowed amount that is primary, and we're unsure. All we know is that some of that allowed amount is being adjusted for coordination of some other type of coverage. Could be an auto policy, could be another health insurance coverage plan. So for the purpose of simplicity, we're going to exclude all claims that have COB. Then we have what we discussed earlier. If a facility claim has an unrecognized Medicare provider identification number or an ungroupable MSDRG, we will have to make adjustments for those. Lastly, we have some claims that have unreasonable, inconsistent, or problematic financial values. So just as an example of two situations that these financial values generally do not pass our data quality review, that's for billed and allowed amounts less than $1, or when the allowed to billed ratio is greater than 2 or less than 0.03. There's additional exclusions that we apply for data quality reasons that we can discuss if there's available time. Next slide. And then there's also these services similar to Seoul Community Hospital where we're considering alternatives to Medicare pricing. And when I say alternatives to Medicare pricing, what I mean is alternatives to the fee schedule that Medicare has published. So for example, on maternity and newborn, there are Medicare associated case rates for these MSDRGs, but the research behind this amount of Medicare pricing is not necessarily overly robust, given that the population that Medicare is dealing with is generally past the age of pregnancy. So one alternative approach that we've presented to the carriers and that we've discussed with Healthcare Authority is to substitute the Department of Veterans Affairs TRICARE payment relativity amounts. These are estimated to be consistent with the Medicare relativities, so they would fit back into the overall evaluation and a replacement for the Medicare DRG weights associated with these categories. And then the second is what we discussed earlier with the Seoul Community Hospitals, where Medicare reimburses on a prospective payment system basis, and we're having to evaluate the legislation on a cost basis. Next slide. Now we're getting into some of the results that we've presented and evaluated under a Medicare pricing methodology that's consistent but not exactly equal to what we will be using on Cascade Care. There's a few components that we haven't been able to yet evaluate, but this presents what the impact would be under a full Medicare repricing where we don't have any add-on payments for IME or DISH and UCP, so that's the disproportionate share hospital and uncompensated care payments. So you'll see right now the methodology is sitting in the middle column, where the public employee experience would be evaluating out to be 170.6% of Medicare. And then if we were to substitute and add the add-ons, but leave the amount of reimbursement for the public employee plans, the network average across all public employee plans would be 165.5%. So the numerator is staying fixed in the most left-hand column, but the denominator for inpatient facilities is going up. So that's lowering the percentage of Medicare from 240% without add-ons down to 201%. And then in the section to the right, that's where we do the same two scenarios with and without add-ons for the full Medicare and substituting TRICARE weights for the maternity DRGs. So this is another instance where you're changing the denominator but leaving the numerator alone on the inpatient facility. And so that would evaluate the current reimbursement for the PEBB plans at 171% with no add-on payments, going down to 166.2% with the add-ons, or inpatient going from 245 down to 205. So in all of these evaluations, we're calculating what the Medicare reimbursement would be under the proposed methodology, similar to Cascade Care, but not exact. We don't have a lot of the cost to charge ratio methods built into this approach yet, and it's showing the relative impact for what it would mean to change the methodology for these two components. Next slide, please. This slide is another slide of results from the public employee program, where we're looking at what the rate of assignment would be for claims on a Medicare basis that, as I said earlier, are similar but not exactly the same as what we're proposing under Cascade Care. So right now, under this evaluation, you'll see that there's 16% of allowed claims that are not currently assigned a price under Medicare. And if you'll go to the bottom two footnotes, we can say that the Medicare covered HCPC under an allowed basis is worth $48.15 of that $59.72. So once we develop the substitution for similar services, that will largely be resolved, and then those services would flow back up into either outpatient or professional at their respective fee schedule amounts for the similar service that Medicare would reimburse. And then when we look at the claims within the PEBB system that do not have an NPI or are assigned a default provider's prospective payment system amount, that's that's $8.24 PMPM, or 14% of the non-assigned. So once we resolve the two adjustments to the methodology that we didn't have reflected in this PEBB repricing, the not assigned should be down around 5% of overall cost. And that's what we believe will be the consistent amount within the Cascade Care evaluation that we eventually will be using this methodology for. I think that concludes our slide deck. If we could just go to the next slide to make sure. Yep. So Rachel, do I turn it back over to you?
Yeah, thanks, Ben. Thank you for that overview and detailed presentation. We have a couple questions, and I'll admit we're having some difficulties reading them, but I'm going to read a couple off. There seems to be many related to critical access hospital and payment. So, Ben, I might punt some to your way. Let's see. So just 1 minute, if folks can just bear with me 1 minute. One question is, how does the public option align with the global rural payment methodologies? Ben, do you want to talk about, since you mentioned in your presentation, I know you didn't talk specifically about our global budget, and there was a global budget proposal the Healthcare Authority had been working on in partnership with others in the community for the last year. But Ben, can you address how some of the alternative payments, as you mentioned, bundled, would be addressed under this model?
So if there is an adjustment for global budget that's being made in the commercial contracted setting, and that would be reflected in the insurer allowed amounts, and then the denominator of Medicare pricing amounts would reflect the methodology on a critical access hospital of the cost to charge ratio. So if there is a positive impact of the global budget on the amount that the commercial insurers are reimbursing to critical access hospitals, that would come through in the evaluation of the claims relative to Medicare.
Thanks, Ben. There was a question about two of the Milliman's final slides and showing how this can compare to PEBB business. I'll speak to that, and I meant to mention this early on in the presentation, or when I introduced Ben. Ben and his team at Milliman did a similar kind of Medicare reimbursement exercise for the healthcare authorities' public employee plans as well as school employee plans. And in absence of some data, we have used Uniform Medical Plan, which is one of the health plans for public employees that the healthcare authority runs. And we've used data from that plan just for illustrative purposes for this webinar. So wanted to call that out, and I don't know, Ben, if you want to add any additional insights to that.
The only additional insight is Uniform Medical Plan is the largest self-insured plan that's under the public employee benefit portfolio. And for this analysis that we did, we pulled together not only that plan's enrollment, but also the Kaiser Washington and Kaiser Northwest plans experience as well, to just inform the overall average level of reimbursement through the public employee program.
There was another question. If a payer's overall payments are determined to exceed price caps, what happens? I'll comment and then ask HBE staff to comment as well as Ben. We're working on a validation approach at this moment, so stay tuned for more details. Another question, will all health plans in the healthcare benefit exchange now be called Cascade Care? I'm going to ask one of HBE staff to respond to that.
No, so we're working on that branding right now, and we're putting a lot of thought into that, and we'll be testing and kind of working with consumers to make sure we get consumer feedback over the next few months on how plans will be presented to consumers, including the naming convention. But what I can say is that, so there will continue to be the non-standard plans offered through the exchange, which will not have any Cascade Care branding on them. We're kind of thinking about right now the potential for the standard plans and the public option plans to be called Cascade Care plans, and wanting to see how consumers react to that sort of naming. But more to come on that work.
Another question received, is Cascade Care replacing Washington Health Plan Finder or Washington Apple, which I assume is referring to our Medicaid plan, Apple Health? No, Cascade Care is not replacing either the Health Plan Finder or the Apple Health program administered by the Healthcare Authority. Another question. It's a question about naturopaths. I know that's a question that's come up with the carriers as well. Naturopaths are not included in Medicaid or commercial plans. However, Medicare does not provide reimbursement for naturopath. And would the public option restrict a patient's ability to access their naturopath primary care provider? Ben, do you want to comment on that? I know we've talked about it before.
I don't believe so. I don't believe there's any restrictions on covered provider types. If we're dealing with a provider type that's not directly mapped to a Medicare covered service, then we will have to work through how we would map that individual provider type into an RBRVS fee schedule, for example.
Another question, are the critical access hospitals going to be paid on the inpatient side at their Medicare per diem rate and then trued up annually, or on the MSDRG basis you just Milliman described, like the inpatient IPPS hospitals, and then trued up to cost annually? Ben, do you want to comment on that?
Sure. So the critical access hospitals right now we're planning to use on a cost reimbursement basis, whether that means we in advance the cost to charge ratio or we assume the interim per diem that Medicare has identified has not yet been determined. But it'll definitely be evaluated relative to cost as the legislation enables.
Thanks, Ben.
Hey, Ben, I have one additional clarification. This is Leah. And just for providers, the public option requirements do not dictate how the carrier pays the provider, only how we will evaluate whether the carrier has met the overall cap.
Excellent point, Leah.
Okay, just wanted to, and I thank you for making sure you're keeping me honest too.
Other question, the value-based purchasing readmission reduction program, which is a Medicare program, hospital-acquired condition facility-specific factors were not discussed. Are these included or excluded? Will this be included or excluded from Cascade Care?
They're excluded currently.
Yeah. Sorry, no, it's okay.
Click on the question.
If I wanted to elaborate on that one particular issue, I'm not sure if we have that data available to make an adjustment, even if we wanted to include it.
I'm not sure the HPE staff can answer this question, but I shouldn't assume. A question about, can you estimate approximately what the lowest deductible available will be?
So in the standard plans, the lowest deductible is a $500 deductible. It's the gold plan. There are still non-standard plans will be available through the exchange. So there could be a lower deductible gold plan that a carrier may choose to offer. But in the standard plans, the lowest deductible is the gold of $500.
There's a question about network adequacy. Are you setting requirements for network adequacy, number of providers, any specialty per 100,000 subscribers? That is left up to OIC. It is our intention that the current network adequacy rules will apply to the Cascade Care plans. Another question, will plans be required to participate in Medicaid Apple Health to offer Cascade Care? No, plans will not be required to participate in Medicaid to offer Cascade Care in 2021. Sorry, little tricky looking at these questions. So a question about value-based payment. When we say it's excluded, does that mean VBP payments beyond the fee-for-service? Does that mean that VBP payments beyond the fee-for-service will not be considered against the cap? Ben, do you want to talk about that?
Yep, that's correct. So if Medicare makes any value-based adjustments to the Medicare payment, we would not have those on a timely enough basis to adjust what our program would consider in the Medicare reimbursement for that year, since those are normally settled after the fact.
Ben, I think this is coming from a provider perspective of if they're reimbursed from the carrier and they get a fee-for-service payment and they also get some other kind of value-based payment, both of those payments would be, if it's for a Cascade Care member, would be included in the calculation about the aggregate rate. Is that correct, or am I not correct?
I think we're at a detail of timing that I don't think we know yet.
Okay.
I think our validation analysis of the 2021 calendar year may need to be done in a time frame that doesn't recognize the settlement amount. It just depends on when that validation process needs to conclude relative to the data that the carriers are supplying.
Yeah.
Another question, what happens if there are bare counties? Sorry, I'm gonna volley this one to the exchange plan, or the exchange.
So there was a legislation in the previous session, not this last session, but the year before that, with respect to, when I'm saying bare counties here, with respect to the exchange coverage. So there's currently a provision that if carriers are participating in SEB or PEBB, they would be required to participate in the exchange in those counties. So that is something that the legislature did to kind of take an action to make sure that there would not be counties without individual market coverage going forward in the exchange. That does not reach the question of whether the public option plan would be available in every county. And so that's just something we'll be looking at going forward to see carriers' ability to make networks and participate in counties as we kind of enter this next plan submission season. We'll be really looking at where, those counties that carriers will be offering in.
Thanks, Christine. Trying to get to some of these questions. There's a question about will we need to contract with Cascade plans separate from our existing commercial plan contracts? I don't know if we can weigh in on that.
We've heard that OIC may have some guidance about this or not, so I think that's a question for them. And unfortunately, they're not with us today.
Another question, does HCA-HB believe the plans already have a network in place to offer Cascade Care, or do they expect this to be built? I'll say we have, I'm not going to say we have an opinion on this. I know that these networks will be built over time, but I don't have a clear sense of when that's going to happen. I think we're running through most of the questions at this point. Again, chiropractic, or not again, because we talked about, but chiropractic care. question about chiropractic care is not specifically listed in the benefits because of the AV calculator. This makes it looks like there's no benefit. Will there be more clear descriptions of benefits? Chiropractic spinal manipulation is not physical occupational therapy.
So yes, it's correct that the categories included in the standard plans are largely based on the categories of benefits that are included in the federal actuarial value calculator. There are many benefits that are kind of included in the essential health benefits in Washington state. Chiropractic is one of those benefits. All of those benefits must be provided through any plan offered in the individual market through the exchange. So all of those benefits will be included in every single plan that's offered through the exchange, all the standard plans, non-standard plans, and public option plans. It is really up to the carrier where they classify different benefits. And the carrier kind of, when they submit their plans to OIC, they work with OIC to make sure those benefits are classified in the correct categories. So that process will continue for 2021, really between the carriers and OIC.
Another question is a small rural health clinic matched with a critical access hospital. Is the reimbursement rate tied to our Medicare cost-based reimbursement rate set yearly? Ben, do you want to address that?
You cut out a little bit, but I believe the question was on the cost reimbursed facilities, will we be publishing the cost to charge ratio annually? If that's the question, the answer is yes.
Yeah, I think that's what the question is. Talking about a rural health clinic, and will their reimbursement rate be tied to their Medicare cost-based reimbursement rate set yearly?
Is that for a rural clinic as in an FQHC?
Nope, there's different designation.
So if Medicare is reimbursing that clinic at a cost basis, have to incorporate that. We were anticipating that all professional services were prospective. We didn't identify any cost reimbursement for rural clinics.
Another question, is there a plan if no carriers submit proposals for the public option or if no proposals are accepted by the OIC? I will speak for the Healthcare Authority. We have no plan in place at this time. We hope we are excited by the public option plan and honored to be part of the procurement and are excited for carriers and providers to participate in it.
This is Jen with the exchange. I would also expect some legislative activity if there's no carrier participation and/or if people are unable to form networks. It was contemplated this session that public option participation could be linked to PEBB and SEB, much like individual market participation. And there's a study that was included in the bill, and I know that's something legislators are looking at.
So for folks, because I don't know if this sounds very good to hear, but exchange staff also weighed in that if there's no participation the first year, there could be legislative action, and that's one option or one thing we're speculating, but that has been discussed. There's some common questions about the UMP, the Healthcare Authority's UMP program, and the examples that we put up. I want to just clarify. This was that exercise was because we were looking at UMP rates compared to Medicare reimbursement. We are not using UMP rates in this for this public option plan at all. Those are completely different products. Again, because this is a complicated topic about what we mean 100%, 160% of reimbursement of Medicare and how that affects inpatient, professional fees, outpatient. We just leveraged existing work to give examples. And so I hope it was not our intent to cause confusion, but just for illustrative purposes of how this could look and will look, absence any carrier-specific data that they from existing plans on the exchange at this time. Question, will the public option be available to all Washington residents, including undocumented immigrants? How will residency be established and verified? I'm going to ask the exchange staff to speak to eligibility.
So the eligibility requirements for the public option plan will be the same as eligibility requirements for qualified health plans generally through the exchange. An individual does have to be a resident of Washington State, and that will be kind of, checked through the process of applying for a plan when individuals come through Health Plan Finder to apply.
Thanks, Christine. I'm trying to look through. I think this covers most of the questions, and I apologize. We have a very small, tiny dialogue box that we're looking through. I guess I'll give folks another minute if they have additional questions, and if not, I'll invite exchange staff if they have any additional comments to make. There are some additional questions that are coming in. You gave detailed information about standard plans. Do you have this information on the public option plans? So, as Christine was mentioning, there are standard plans are the public option plans. The public option plans are the plans that are required to have the Medicare reimbursement provisions that Milliman outlined, that we outlined, as well as the additional standard requirements of the BRE and the health technology assessment, other value requirements. There will be QHPs, but those will not be public option plans. Both will be offered under the exchange, on the exchange in 2021. I don't know if we want to. It is confusing to folks, but does anyone else want to make some comments about? Yeah, we'll send. We'll send out the slides. I know Christine kind of talked about the 3 different areas, and hopefully that is helpful for folks, as well as the Healthcare Authority and the Health Benefit Exchange have websites on Cascade Care that I think give a nice overview of addresses some of the questions that have been asked today. Question, how will outlier payments be considered?
So we'll be making outlier adjustments when we process the Medicare reimbursement under the prospective payment system using the facility-specific cost-to-charge ratio.
Thanks, Ben. Where and when will CCRs for cost reimbursed facilities be published?
I believe they'll be published through Healthcare Authority. I'm not sure on the when. Rachel, are you thinking we would wait until post OIC product approval to publish what that criteria is?
I think those details need to be worked out, and we'll have hopefully more details to share soon. I'm getting some comments, which are great, but they're not exactly questions. But I encourage, and some of them are really good insights and suggestions for us to consider. We will keep a list of these questions, and we also encourage you to share some of these, your input, the similar input during the public comment period, which should be launched shortly, and we'll be sending out an email of when that starts in the next week or so. Are there any other closing comments from the exchange staff? Or
No, thank you.
Yeah, thanks for your participation.
Yes.
Yep, thank you very much for participating. This recording will be posted on our website as well as the presentations. Again, we're excited for Cascade Care and we look forward to your participation. Thank you.